Good morning, everyone. Thanks for joining the meeting today. Welcome to our Pharmacometrics Symposium, Spring 2021. Happy New Year to all of you. Today, the symposium is going to be about learning the role of pharmacometrics in the practice of pharmacy and medicine. We have two outstanding speakers that are going to share their knowledge with us today. The session is going to be for 20-minute talk, and I will moderate few questions after the talk. Please provide your questions in the chat box. So with that, I would like to start introducing our first speaker, Dr. Michael Neely. Dr. Neely's research and clinical interests are in the clinical pharmacometrics, including population pharmacokinetic and pharmacodynamic modeling, pharmacogenomics, biomarker control, simulation, and most importantly, use of models to optimize therapy for individual patients. He's a practicing pediatric infectious diseases specialist. He is the chief of infectious diseases and director of the Laboratory of Applied Pharmacokinetics and Bioinformatics at the Children's Hospital of Los Angeles, and an associate professor of pediatrics and clinical scholar at the University of Southern California Keck School of Medicine. Dr. Neely created PMetrics, a non-parametric and parametric population modeling and simulation package for R based on over 4 decades of work by members of his team. He also created an R package for best dose software to optimize drug therapy for individual patients. He has a master's degree in clinical and biomedical investigations from USC. He periodically consults for the US Food and Drug Administration Anti-Infective Drug Advisory Committee. He is a regent of American College of Clinical Pharmacology, a founding member of International Society of International Society of Pharmacometrics, and an active member of the International Association of Therapeutic Drug Monitoring and Clinical Toxicology. He has published more than 100 peer-reviewed articles, mentored numerous visiting scholars, and is an invited speaker worldwide. I'm very glad that he could speak in our symposium. Thank you, Dr. Neely, for your support. I would like you to share your presentation and go ahead with your talk.
Thank you, Ayappa, for the kind introduction. I will share my screen here. Okay, let's get the show started. Now, I have actually a lot of slides, and somehow I got confused on the timing. So I'm going to happy to make the slides available to you all, and but I'll kind of do some summarizing and skipping of some slides during this presentation in order to try to keep to the 20 minutes. So I'm going to be talking to you today about clinical pharmacometrics and how does it matter for a physician or any other direct patient care healthcare worker. So just one quick disclosure, best dose, which Ayappa mentioned, is made by our laboratory, but we've now licensed it for the last couple of years to Insight RX. It's still available either as shareware or free versions. There's various versions, and you can email our lab to obtain those if you're interested. Our website is LAPK, Laboratory of Applied Pharmacokinetics.org, and happy to send that to you. Okay, so why is one-size drug dosing naive? You know, this is kind of the paradigm that we live with as clinicians when we're trying to prescribe doses. And the reality is, if you look at a model of vancomycin, we'll talk a little bit more about models if you're unfamiliar with that concept. An average adult getting a 1 gram every twice a day dose is going to have a concentration time profile that looks something like this, with a peak of about 40. Now, this would be the last dose after maybe several doses that steady state was achieved. So you could see that the concentrations tail off over the ensuing couple of days. So this is sort of the ideal, and this is the assumption when we use a fixed dose, that everybody looks like this. But in fact, everybody looks like this. So these little black circles are concentrations that were measured during a prospective clinical study that I conducted that we will talk about later. And the red lines are different profiles predicted by the model in terms of just possible. We're simulating for the model. We're not trying to fit the data, we're just simulating. So you can see there's a tremendous variability around that sort of typical ideal assumption of what a patient would look like if they got 1 gram every 12 hours. And in fact, those concentrations were actually supposed to be obtained as trough concentrations as this study. And so they should have been within that little yellow box, both vertically in terms of their desired concentration and horizontally in terms of the desired timing for every 12-hour regimen. So you can see that both the concentrations are way outside that box and the timing is certainly not anywhere close to ideal in a clinical situation. So trough concentration monitoring is not exactly as easy or well executed as you might assume. So I would argue, and I published an opinion piece about this a few years ago now, that we as prescribing physicians who are not surgeons ought to learn how to use our drugs like a surgeon uses a scalpel, with some finesse and dexterity, instead of the one size kind of sledgehammer approach that most of us are currently sort of forced into. And really the solution to allow us to do that has gone through various names: therapeutic drug monitoring, clinical pharmacometrics, all sorts of ones. But I think probably people seem to be settling on model-informed precision dosing, or MIPD. And the goal of that is to model the drug behavior in patient populations, and then from my perspective, use those models to optimize dosages in single patients. So how do we kind of do better? How do we reach for the stars? And this is a picture I took outside my home in Southern California. Or maybe the nearest bar, if you're looking for a lifeline. And this is me being forced to participate in some leadership course, jumping off a telephone pole. So just fundamental, and I'm going to try to not make this very mathematical at all. You need to understand something about Bayes' theorem if you don't already. He was an 18th century mathematician and Presbyterian minister, one of those old Renaissance guys. So just imagine for a moment that you have a bag with 10 coins and one of them is defective and has 2 heads, and your friend chooses one of them to flip. What's the probability that your friend chose the one defective coin among 10? And I think most of us could easily say, well, if there's 10 coins in the bag, one's defective, the probability is 10%. However, if your friend now flips the coin 5 times in a row and gets heads, I don't know whether it's the fair coin or not, what's the probability that the coin is defective? Intuitively, you can say, well, geez, if I got 5 heads in a row, it probably was not the, or it may have been the defective coin. I'm going to revise my prior probability of 10% to something higher. I don't know what it is, but it's higher. And there's a whole big formula that you can use to calculate it. And the number comes out to be 78% chance. So now I have a 78% chance instead of a 10% chance. I have revised my predictions based on some data in front of me. And we can do simulation to prove that that's actually true. Simulating it thousands and thousands of times over, it comes out to be exactly 78%. So this is something that we all do intuitively, whether or not we know how to do the math. So we can use Bayes' theorem in population modeling, which then allows us to do individualized dosing. And this is a picture I took of the Milky Way over Death Valley, which is one of the darkest places in the world. So the concept here is that your patients are not therapeutic islands. They're not the first person in the world to ever get the drug that you're prescribing. So you want to build a model or have a model or use a model to help you optimize dosages and individualize that therapy. And a model is nothing more than a series of equations that links input to output, dose to concentration. And a model, those equations have variables or parameters such as volume or clearance. And the goal of the modeling exercise is to estimate values for those variables in a population, a study population. So we may have an estimate of the distribution of clearance in a population that looks something like this, which is a normal distribution, very familiar, easy to understand. Or we could maybe do it in a so-called non-parametric way where we've got a distribution that looks more like this. Each spike is a value for clearance in the population or elimination or volume or whatever we're talking about. And the height of the spike is the probability. Higher probability values describe the data a little bit better in the population. Lower probability, not so well, but they're not impossible. Or on the box on the right, you could see now we've plotted two parameters in two dimensions projected to 3 dimensions. Again, the height being the probability. So this is a model now. This is a model of drug behavior. It contains variables and values for those variables in my population. In the Bayesian terminology, I'm sort of capturing my past experience for the drug. This would be like my 10% probability for that coin. This is the probability sort of how the drug is going to behave in my patient before I measure anything. So there we are. It's the past experience with the drug. Now, if I start to measure things in my patient, including just covariates like weight or height or sex or whatever else is important for the drug, I'm going to influence my past model, my prior, into some future prediction or posterior for my patient. And you could see mathematically how this works out with the non-parametric sort of representation of my model on the left and the parametric on the right. If this is where I start, I measure some data in my patient, and I end up with my posterior. Now, some of those points are no longer very likely because they don't describe the data in my patient well, and so they've been eliminated. Some of them have raised up, got higher probability because they did a better job of describing my patient. But you can see I'm combining information from the past along with my patient current data. So again, my patient is not a therapeutic island. So how does our software use it? So each of those points, we favor the non-parametric. So I'm going to kind of focus on that for now. Other tools will use a parametric, and it's a similar but not quite the same approach. So each one of these support points, as we call them in the model, is now a version or a possible model of my patient. So it's multiple models. Some points with high probabilities do a good job explaining the data. So if you look at the top little yellow inset box there, maybe these open circles are measured concentrations, and the predictions that come from this point here, remember this point has values for elimination, volume, et cetera. It predicts a time concentration profile that goes through those measured concentrations quite nicely. So that's why its probability is higher. Whereas these parameter values here, this lower point, don't go through the measured concentrations in my patient so well, so the probability is lower. It's not impossible though. Maybe there's some error, maybe there's something I haven't accounted for. So each one of these support points is a version of my patient, a model, one being particularly good in this case. And the software then, if you give it a target, let's say in these green squares here, so I want this concentration 12 hours after a dose, this concentration 12 hours after the next dose, then it's going to just mathematically run through a whole bunch of different doses, give them to each one of these points in the patient's individualized model, the posterior model, and take the weighted average over all of those support points to generate these various profiles. So here would be the profile, weighted average profile from dose 1. The red is the weighted average profile from dose 2. And you can clearly see that dose 1 hits my targets better. So this is now the optimal dose for my patient. How do we use this in real life? All right, here's one of my favorite patients. I'm a pediatric infectious disease specialist, but I used to work in a family-centered HIV clinic. So one of my adult colleagues came to me with this challenging patient. She was 45 years old, HIV infected, long history of intolerance. Everything gave her a side effect. She was new to our clinic, started on, at the time, a fosamaprevir or Lexiva containing regimen, no ritonavir because she knew she couldn't tolerate that, and was given two 700 milligram tablets twice a day, so a total of 2.8 grams a day. And she complained of daytime fatigue, which she attributed to those 2 morning tablets. So this woman, she did want to be healthy. She inquired about taking the entire dose at night, and otherwise she didn't want to continue. So we have some bad options, I would argue, and one good option as her provider. And this is where the pharmacometrics is so important. We can tell her the problems in her head and press on. Well, obviously we know what's going to happen. We could just say, all right, let's cross our fingers, change to the 4 tablets in the evening and hope that that works. Of course, that's not very responsible in terms of selecting for resistant virus if we're wrong. or maybe we're going to end up with some bad side effect because she's now taking a very big dose once a day. We can just shift her to another regimen, but she's done that many times before. Or the best option, in our opinion, is to measure the active drug and attempt to do something rational. So that's what we did. And on her standard dose, we measured a concentration of 1.4, 4.5 hours after her previous dose, self-reported time. We had asked her to stay on the regimen at least long enough for us to do this. She was wild type virus, thankfully. So the target was 0.23 to 0.4 as a trough concentration. So now the question again is, can she actually do all 4 pills at night? We can model the data that we have, and you can see the red circle here is her measured concentration, and the black line is the weighted predicted profile of 1,400 milligrams twice a day in a woman her age and size. We get a very nice tight prediction, and we can see then that her predicted trough concentration, even though we didn't measure a trough, is 0.27. That's within our range of 0.2 to 0.4. So on the standard regimen, she's about where she needs to be, and that's kind of expected. But we can now play with her model and simulate and see, well, what would it take to get a once-a-day regimen that would maintain that same trough concentration? And the software is saying, all right, well, you'd have to go from 2.8 grams a day to 43.5 grams a day if you really wanted to do that. So now we can clearly say, now you may quibble a little bit, okay, maybe it's not exactly right, but it's certainly not even close to the 2.8 grams. And there's no way that she would be able to maintain her virologic control, I would argue, by taking only 2.8 grams a day once a day. She would be way below her target concentrations for most of the day. So then I started exploring some different regimens, and this is the power of having a model and a software tool to use it. I could say, well, what if I gave her 3 tablets at night and 1 in the morning to sort of offload the fatigue to the evening? And her pre-dose evening trough concentration after that low morning dose was only half of what it ought to have been, and I wasn't comfortable. You know, we don't really know how long do you really have to be above the trough the entire time? We don't know. But I wasn't happy about leaving her below that trough for maybe half the day or so. So I didn't quite give up yet. I then looked at an every 10 and 14-hour regimen, which sounds so contrived, but if you end up taking your medicine with breakfast at 8 a.m. and again at dinner at 6 p.m., that's now a 10-14-hour schedule. And that actually was predicted to have her maintain a reasonable trough. So that's what we recommended with all the usual disclaimers, and measured a follow-up concentration. You can see it was exactly what we had predicted. And lo and behold, her fatigue disappeared, her viral load went to 0, her CD4 count climbed, and we had winning all the way around, right? She was happy, we were retained a patient, and the drug company retained a client because she didn't shift away from their regimen. Success all around. Now, we don't really have time to go through the other patients, but I'll just summarize them. Here was an 18-year-old who basically wasn't taking her medication. And we measured a concentration to be able to show to her and prove to her that she wasn't. We couldn't get her to admit it until we actually did this. So we could actually now measure, say it's undetectable way down here, and quantify the probability that she'd actually taken the dose when she said she did. And it was basically almost 0. And so we were able to have a therapeutic breakthrough with this young woman and say, well, we know you're not taking your medicine, but you're still okay. We still want to take care of you, and we're in your camp. And we figured out a way to help her get her medicine into her. And she also drove her viral load for the first time in her 18-year-old life down to 0, and her CD4 count rose above 50 for the first time in many, many, many years. I had another patient, a 7-year-old, this is not an HIV patient now, 7-year-old with a brain tumor that got in a cavity that got infected with MRSA. His primary team kept jacking the dose up of vancomycin because they couldn't turn the cultures negative or get him afebrile. And despite a target trough of 15 to 20, they couldn't get above 8 in him. So we used our modeling software to come up with a continuous dosing regimen. This was the planning based on the fit of his past data. This was what we actually achieved with only an 8% error. And within 24 hours of our new regimen, he was afebrile and culture sterilized. So we don't only do this in individual patients. We've done several studies, and I'll just highlight one of them here for you. It was a prospective study of Bayesian adaptive control of vancomycin. And the original hypothesis was that patients are really overdosed, that when we look at trough concentrations and judge them to be therapeutic or not, many times we're saying they are subtherapeutic by trough, but if we looked at their area under the curve, they would actually be therapeutic. So in year one, we just looked at standard therapeutic drug monitoring, what was happening in the hospital. They were using trough concentrations, measuring them and comparing them to the IDSA, Infectious Disease Society of America guidelines. In year two, we kept using trough concentrations, but we used those to generate now a Bayesian posterior for each patient and targeted an AUC. So we used the trough to generate the posterior, but we didn't target the trough. We targeted an AUC. And then in year three, we did the same thing, but we no longer used a trough concentration any longer. We used an optimally timed sample. So the concept there is that some sample times give you more information about your patient than others. As I said, we used the IDSA trough concentration guidelines at the time for year one. And then in year 2 and 3, we used an AUC to MIC target of 400 when we had the organism and it was MRSA, and a straight AUC of 400 for others. We tried to keep the cap at maximum at less than 800 to minimize the chance of toxicity. The study population was similar with respect to age, sex, and weight. Each year, you can see that we had some fairly small adults and some very large adults ranging up to almost 200 kilograms. We did take patients with baseline renal dysfunction as long as they weren't on dialysis. So some of our serum creatinines were pretty high in the various years, but not significantly different. And creatinine clearance, of course, reflecting that. So some of our significant outcomes that we found, we did a significantly borderline, but significantly fewer days of vancomycin, mostly because we weren't, when we used Bayesian control, mostly because we didn't see the sort of seesawing that happens when you do trough concentrations. You get a low concentration, it's you need to adjust the dose, you wait for another 3 to 5 doses to get to steady state and check again, and that really delays things. Whereas with the Bayesian, you don't have to wait at all. You can just check as soon as you give your new dose. We also then therefore had significantly fewer samples per patient. And of course, we had a lower trough concentration in years 2 and 3 because we weren't targeting it any longer, and we were targeting AUC. Our primary outcome, back to our hypothesis, indeed, we did strongly prove that AUC, you were much more likely to be therapeutic by AUC, which is really the driver of vancomycin efficacy. And this really matched up with some predictions that we had made about 3 years earlier by simulation. We had predicted that among patients with an AUC of more than 400, 32% of them would have a trough of less than 10. And in our real study population of those who did have an AUC of more than 400, 31% had a trough of less than 10, which is not considered therapeutic by any trough guideline. They're therapeutic, but if you were looking at trough, you would say they were subtherapeutic and you would have needlessly raised the dose. And again, these simulations were made 3 years before these data were collected, and it was an exact match. One of our biggest outcomes that we found is that there was significantly fewer patients with nephrotoxicity in our Bayesian control years, because we were again targeting AUC and not overdosing our patients. And this was linked to initial trough concentrations. Higher trough concentrations are more associated with subsequent nephrotoxicity, and we found that. That's been published by many other authors as well. And not quite significant, but certainly higher initial AUCs are also associated with nephrotoxicity. And the big thing to recall is that the length of stay is considerably longer if you have nephrotoxicity. And at a simple analysis of daily bed charge, this equates to an awful lot of money. And one other point, just that I told you in year 3, we used optimal samples. You can see that almost all the time they are not trough concentrations, less than a quarter of the time. So trough concentrations don't tell you as much about your patient as getting samples at other times do. And the last slide on this vancomycin study, and then I've only got a couple more slides and I will be done, is you can just see the effect here of how well you know your patient and how well you're able to control their therapy. So here we are in year 1. This is called a violin plot. sort of the width of it is where the bulk of the data lie, and we're looking at AUC to MIC here. So the point here is the weighted mean for each of the distributions. You can see with our target at the horizontal black line here of 400, we're way above where we need to be when we're targeting trough concentrations, i.e. we're overdosing our patients. When we actually control AUC with a Bayesian approach, and it's very difficult, or it's harder to control without the Bayesian approach, then you start to do AUC, because then you have to start getting into at least 2 samples per patient as opposed to the 1 that we were using. But you get much better control. Now remember, we weren't optimally sampling here, we were using trough concentration, so there is still a little bit of error. When we now control AUC and we're using optimal sample times, you can see how tight our control is over our patients' exposures. And I will tell you that this, I'm proud to say that this study really is, I would say, was the prime driver of completely revising the vancomycin guidelines. So in 2020, the second version of these, originally published in 2018, came out and flipped the emphasis from trough monitoring to AUC and said, if you can, you should monitor AUC as opposed to trough, and actually named our freely available best dose software by name in these guidelines. And I'll give you one last tidbit. For busulfan, we did something in our hospital also using Bayesian dosing and optimal sampling. We went from a standard regimen of preparing children for bone marrow transplant with busulfan conditioning. They were getting 9 blood samples to estimate AUC with very, very high accuracy. This was the standard approach in our hospital. We showed that we could, but yet they were, by dose 3, if they continued to do this, they were very inaccurate because they actually had an error in their formula. We showed that with 9 samples, we could, of course, be very accurate. So we're comparing this to a gold standard reference laboratory dose calculation. So with 9 samples, but here's the important part. We could be equally accurate. This is bias on that we're showing here, bias with the gold standard dose recommendation. We could be equally accurate with a Bayesian approach and 2 optimally timed samples. And this has caused our hospital now to go from 9 samples. They couldn't quite bring themselves to go to 2, so they went to 3. But from 9 to 3 samples for our patients routinely. I think this is the lowest number of samples routinely used in the United States, making our hospital, I would argue, the leader in the country. All other hospitals, as far as I know, use 4 to 6 samples for busulfan AUC estimation, and we're using 3 and really could use 2. And this is all possible with Bayesian calculation and optimal sampling. The FDA is interested in this. There was a workshop back when we were all allowed to travel and be in rooms together back in August of 2019, and there is a website on it. So this is the wave of the future, folks. Obviously, I can't do this work without a lot of help, so lots of acknowledgements, funding from NIH and from this UO, and is from the FDA. And with that, I thank you for your attention.
Thank you very much, Dr. Neely, for a wonderful presentation.
Let me stop sharing my screen for you, Yapa.
Sure. So in the interest of time, probably I'll ask one question from the panel, from the participants, and then we will take more towards the end. So one question is about P-metrics. Great talk. All best dose models were built with P-metrics. They're asking whether all the models are built using P-metrics or not.
For our software, yes, the models are built with P-metrics because best dose uses the non-parametric approach with the support points as a discrete distribution. So they do need to be built in P-metrics. There are other software tools out there. InsightRx, in fact, has both parametric and non-parametric. So other modeling packages that use parametric approaches can feed into dosing software. And there's freely available ones as well that you can look up that will use a parametric approach. Our older software, USCPAC, used parametric approaches as well, but we feel there are some mathematical advantages to the non-parametric.
Thank you. With that, I would like to move to the second speaker, and we will have some more questions towards the end. Thank you very much again, Dr. Neely.
Sure, and I'm going to try to answer some of the questions in chat. I'll chat back as you're going on.
That will be great. So our next speaker today is Dr. Dewey Benjamin Tran. Dr. Tran received his Doctor of Pharmacy from Temple University. During pharmacy school, he taught biostatistics within the Department of Public Health, supported statistical modeling for faculty and clinicians, and interned at the Children's Hospital of Philadelphia Department of Pharmacy. After completing pharmacy school, he pursued postdoctoral training in pharmacometrics funded by the NIH, which was co-sponsored by Children's Hospital of Philadelphia Research Institute and Thomas Jefferson University Hospital. He's a board certified pharmacist in pharmacotherapy. Dr. Tran has worked as a pharmacist in the investigational drug services and hospital setting to provide pharmaceutical care to pediatric and adult patients. Dr. Tran is currently Associate Director in Pharmacometrics at Certara. Thank you, Dr. Tran, for accepting our invitation, and over to you for your talk.
Thank you. Yeah, but let me share my screen. Okay. Yeah. So yeah, thank you so much, Ayappa, for inviting me to give a presentation in this seminar. The title of my talk is How to Become a Better Pharmacist: Understanding Pharmacometrics in Dose Selection of Commonly Prescribed Medication. So the goal of my talk is I don't have any equations or diagnostic plots or just hysteresis. Yeah, I just want to give my perspective as a pharmacist on how pharmacometrics, and when I define pharmacometrics, in this presentation I want to keep it as fundamental. So looking at exposure and how that varies from patients to patients, and I apply that in drugs that we typically see in pharmacy. So yeah, so the objective of my talk is yeah, just for future pharmacists who are interested in this domain, and just to appreciate what pharmacometrics is and its impact on how on pharmacists, and how we can use it to provide better care for patients. So so as a pharmacist, you I listed here, these are just typical things we do as a pharmacist in patient care. We make sure, I mean, the orders that we get or the prescription is indicated for that diagnosis. We check allergies, duplicate therapy, just to make sure that, yeah, why is the patient getting penicillin and also amoxicillin at the same time? And we compound drugs to tailor to certain patients, and we dispense, and we make sure that the patients understand what the drugs are being used for, its safety, and yeah, what's it intended to use for, yeah, those are the typical role, but how, yeah, where does the pharmacometrics come in? I want to, yeah, again, in this talk, I would focus more on the fundamental, understanding exposure and why do we observe variability in some patients and others. So yeah, so and then I'll give examples, and I guess the model with that application with the drugs are a little more complicated, but there's no equations or math in my talk. I just want to inspire and hope there'll be more pharmacists pursuing this path. So in my first example here, I talk about generic drugs. So according to the FDA in the United States, 9 out of 10 prescription fill are for generic drugs. And these generic drugs, they have the same active key ingredients, same strength, and yeah, the same dosage form and the same route administration as the counterpart brand name. So in essence, they should be of the same quality as the brand, and the safety and and also efficacy should be equivalent. And pharmacists play a big role because we ensure that healthcare is expensive. We want to make sure that patients can pay for this care, and generics medications are a way for us to substitute for the brand name. Okay, but so let me just define how a drug gets to its equivalency to the brand. So the FDA defined this bioequivalence, the similarity, as in these drug substances in 2 or more identical dosage forms reaching systemic circulation at the same relative rate and to the same relative extent. So they're looking at these PK parameter Cmax and AUCs. Again, there's no modeling here. We just want to understand fundamentally exposure. And yeah, this requires no model. You just collect samples over time for your drug and just understand what the peak. So it gives you a relative rate and the AUC, the area under the curve, to understand the exposure of these 2 formulation. And the FDA declared bioequivalence as both Cmax and AUC be set at 20%, such that this 90% confidence interval of the ratio of the log transform pharmacokinetic parameter for the test and reference lie within 80 to 125%. So this is just a regulatory cutoff for this bioequivalence. And there are some limitations with this definition, because again, it relies, the statistical approach relies on mean values. So if you have some patients who are on the lower end, yeah, again, everything gets averaged in, so it can be bioequivalence in the end. But typically for this interchangeability, it works fine for drugs that have wide therapeutic index. But we have to be cautious as pharmacists, because drugs with narrow therapeutic index, yeah, which is defined as the dosage that induce desired effect, in that it's quite narrow, and it could lead to toxic effect if it reaches within that range. So as pharmacists, we even if a prescriber puts down a brand name on the prescription, we can dispense the generic drug unless the doctor writes no substitution. But careful consideration is needed for narrow therapeutic index drugs. And I listed here, these are some that the FDA noted as just being cautious for when you're substituting. Yeah. So when you order, get new shipment for drugs based on cause, I guess making sure that, I mean, the manufacturers are consistent, if not, just letting the patient be informed of these changes. But so yeah, just understanding exposure, and again, there's no modeling here. Just and I just want to. That was my first example. Okay, my next example is, okay, so we have ourselves, this intrinsic factors, and we also have our environment, extrinsic factors, and these play a role in drug exposure variability. So let me start out first with some extrinsic factors. We have food effects. Okay, so you take a drug, and what happens to that? So with food, how does it alter exposure? Okay, so when you eat something, your food is in your belly, so it delays gastric emptying it, and with the food in the stomach, it changes the pH of the stomach. So yeah, increased blood flow to the intestine, and also there's some food. When I say food, it could also be liquid too. It can interact with the drug, and we put all labels to warn patients what drug can be taken with food, without food. So that's part of our message to the patients to ensure that, they get the the most out of the drug that's being prescribed. So with food, they can have no effect after you take it, or there could be some negative or positive food effect. So for negative, after you take a meal, the exposure diminishes quite a bit, and for positive, there's a increase in exposure. But in terms of defining if there's a food effect, it's very similar to the bioequivalence that I mentioned previously. So I want to give one example that I can think of that there's a negative food effect. So Tacrin, this is a medication for Alzheimer's disease. Taking Tacrin with meals have shown to reduce plasma level by 30 to 40%. So patients who take Tacrin should take it between meals if possible. So so food effect is one extrinsic factor. So patients, they don't just take one drug, they take multiple drugs, probably a lot of drugs too. So drug-drug interaction is another issue that pharmacists we need to be aware of, and that's influencing the exposure level of one drug to the other. So I give you here an example, simvastatin, like many other cholesterol HMG-CoA reductase drug. It's a substrate of CYP3A4. So when simvastatin is used with another inhibitor of CYP3A, there's elevated levels of the drug, and it can cause increased risk for adverse events such as myopathy and rhabdomyolysis. And here is directly from the labeling for simvastatin. These are very strong inhibitor of CYP3A4, and it's indication of what to do. So for strong, you avoid simvastatin, and for some of the others, there are thresholds to not to go over for simvastatin if they're taken with the other interacting drug. So I gave two examples of extrinsic factors. And it's in addition to extrinsic factors, or there's stuff that we just inherit ourselves. So I give an example here of sex differences. I think this is the only one that I can think of where there is a dosing label for sex for male and female. So this drug zolpidem used to treat insomnia. It was approved in the early 90s, but it's not till 20 years later until the FDA put out a statement warning about these exposure differences in women compared to men. And so the post-ingestion wake-up blood levels in women were much higher compared with men. And so here I indicated the labeling for Ambien, and you see that the dose, the starting dose for women is half that of men. Very interesting that's fine put place, but it wasn't until years later until we have, I guess, more data, and it just clearly shows that there are differences in exposure in women compared to men for zolpidem. Okay. The next example I want to show is sulfasen, just to illustrate. So before I just show you an example of exposure differences between different factors, but this drug is used. One of its indications for prophylaxis of post-operative infection, and you give it before surgery. And I wanted to point out, and you repeat it if the surgery is longer, so it's every 4 hours. So I wanted to I guess stress where is this 4 hours coming from? So there's this really idea in how sulfasen work. It's best, I guess, it has this time dependency bactericidal killing. So to get the most out of that, you want to maximize duration of the exposure. So if you can get the exposure level, so if you take cefazon here, this is a typical. I just want to illustrate. So if you can get the cefazon exposure above this minimum inhibitory concentration, then that will maximize its killing of that bacteria, and this is a really nice paper done by Dr. Heimenbach, showing that, so he had measured plasma level and also microdialysis, which is I guess a surrogate for penetration in skeletal muscle. But you see here in the plasma plot here, and this line here represents the 4-hour mark. You see, yeah, some patients are above this MIC here for MSSA, methicillin sensitive Staph aureus, but some are below. But it's redosed again for longer when surgery is longer to ensure that we get killing of this drug. And this 4-hour mark, this arrives from the half-life of cefazon being 1.8 hours IV for IV formulation. By 4 hours, I guess 2 hours later, we have only 25% left in of the drug in the body. So that's what I want to show you for I guess this example here, where we have some exposure and the PD component is this MIC above this threshold. Okay, the last example I wanted to give it's recently published, but I really like this research here. So it's looking at respiratory depression potency on fentanyl. Okay, and it compares population that chronically use high dose opioid and patients who have never received opioid before. And this PK/PD modeling examined the chronic tolerance to respiratory opioid effects, and in which they escalate the IV dose of fentanyl to these two type of population. And then the PD is the ventilation, the iso hypercapnic ventilation. And what they found was that fentanyl was 4.3-fold less potent in chronic opioid user compared with opioid naive individuals. Okay, that makes sense, because I guess there are little patients who are more exposed to the for opioid. There's some tolerability there. But look at this. For apnea events, that's I guess one of the safety events. It did occur in opioid tolerant individual, but it's at higher doses than opioid naive individuals. So why did I share this modeling here, showing that yes, there are AEs that you can achieve with patients who are more tolerant for higher opioid doses than naive. I share that because, yeah, opioid is a big problem in our practice, and this is a lawsuit that happened back in the early 2000s, where this patient, I'll just tell you, patient Nicole D, she got a prescription for a fentanyl patch from her doctor after she got a cesarean section. She didn't fill this prescription, and then 4 months later, she had to fill at Walmart pharmacy because she broke her ankle and had some acute pain. So after she applied the patch, she died in her sleep from toxic overexposure to fentanyl. And then the husband alleged, hey, the pharmacist, you should have seen this prescription was more than 4 months old, and you should have questioned that she was opioid naive and should have warned her about the danger and may call the doctor. And then in the end, the court, yeah, they say when a pharmacy fills a prescription which is unreasonable on its face, even if it's lawfully written, it may breach its duty to use improper care in filling a prescription. So the aftermath of this, we don't know because there's no proceeding afterwards, but they probably settle. But yeah, opioids is a big problem, and I guess the key thing is that severe, fentanyl, it should only be used for severe chronic pain, not acute, in like what she used, and it's only for opioid tolerance. So there's since 2007, the Institute of Safety Medication Practice, they've instituted guidances for how to use fentanyl, and and they emphasize that the patches should not be used in opioid naive patient, and they recommend for opioid naive to start low, and these are equivalent. These oral doses here are equivalents. That's the example I want to share. That's the last example. But yeah, so in summary, drug exposure difference survive from various factors, and I just illustrated just a few there. So I guess you're seeing this black box on what the models can do, but there's methods in these pharmacometrics that tries to explain this variability. So in the end, we just to ensure where this threshold and safety is, so that we don't go too far in the efficacy boundaries to get to safety issues. So that's what I wanted to talk about. But yeah, my goal is so why should you pursue pharmacometrics? We have the pharmacology and therapeutics domain expertise. So I feel like that's very, very critical. I mean, our limitation is just the programming skills and the statistics, but these can be learned. I feel like it's not too bad to learn. But I hope I inspire pharmacists to pursue this opportunity. So that's all of my talk today, and here's my contact if you have any questions on pharmacist role. I just gave just a snippet of it, and not too technical, so you can understand just the fundamental what's the key idea when we're doing all this modeling. So I want to thank you very much for your attention, and the invitation for me to speak today.
Thank you, Dr. Tran, for a great presentation. It is certainly echoed very well with the pharmacy background person, and as you said, pharmacometrics, although the word is new, it's really to the core of what pharmacology, and it's really the quantitative pharmacology which deals with understanding exposure response. And also Dr. Neely echoed as well, although we are using several names of therapeutic drug monitoring, precision dosing, etc., it's all coming down to what pharmacists have been doing in a way to the core to individualize therapy. The tools and techniques are changing, and it's time for us to learn. So, and I really appreciate your advice, and as a pharmacist, to give a call to learn these tools and techniques so that we are ready for giving the best care to the patients. Thank you very much.
Yeah, thank you.
I would like to ask one quick question in general that maybe for 1 minute, if you can respond. As a pharmacist, you obviously did this venturing into statistics and modeling. And what do you recommend to our students to take these opportunities available to get into pharmacometrics training?
Yeah, so at the moment, there are just tons of resource on the internet on learning how to code, learning statistics. There's a variety of resources. The hard thing is picking which one to start with. I hope, yeah, if any of um, pharmacists or pharmacy students interested in this career path, just yeah, you can shoot me. You know, I can guide you what I did, but yeah, for me it was just I was just yeah very interested in stats and how this amazing tool is able to answer yeah very important questions related to patient care. So that's just a motivator for me to learning that. So yeah.
Thank you, Dr. Tran. And also thank you for giving a lecture in our certificate program for pharmacometrics. So with that, I would like Dr. Neely as well to join, and I'd like to take some questions from the chat box we got. You already responded to many of them. There is a question, should the pharmacometrician be aware of all the modeling software?
I'll go first with that. I don't think so. Again, my toolbox, I think it includes R. It's free and it can do so much in terms of data manipulation and data visualization. And it's, yeah, again, it's free and you can create beautiful graphics with that. And in terms of modeling, the gold standard, I think, for everywhere is non-mem. So you don't need to learn everything. But I would start there if you're confused of which tools to pick from.
Dr. Neely, you have any comments?
Well, of course, I would offer a counter to that. I would say the gold standard is mathematically flawed, non-mem. There are some, because it's basically at its heart, it's an approximation. They do have better algorithms now, so it's certainly the most widely used. It's also not perhaps the easiest tool to pick up, so there's quite a steep learning curve, and it's generally far from free. So if you're looking for a free tool, maybe look to other places. There are free versions of Monolix. There's certainly a free version of our software. Even Phoenix, I think you can get for free if you're using it for academic purposes, although there's I think a fair amount of paperwork you have to do to show that. But so there's a lot of free tools out there, and I think that would be a better place to start. But definitely non-mem is the most widely used and probably the one used the most in the pharmaceutical industry in terms of getting a job. However, you can, I think, pretty easily learn techniques and the methodologies of population modeling using one of the free tools.
Thank you. I have maybe two more questions. I have a question from our ID pharmacist, ID specialist here at UNT, Dr. Crystal Howell. When developing models, you need patient level data. Have you had difficulty finding labs that will run the levels in a timely fashion? For example, my hospital does not do beta-lactam concentrations.
Yeah, I answered that in chat, but I'll just reiterate what I said, that definitely this can be a problem, and it's obviously going to be very dependent on your lab. So if you have a strong interest in monitoring and measuring a certain drug class or specific drug, then you're going to have to work out something with either a research lab or a that is CLIA approved so that you can use it for patient data and reporting, or with your own sort of hospital laboratory to try to bring that assay on board. Generally, to be honest, the assays, there are enough assays that are published that it's not very difficult to bring a new assay on board, but you do have to get the buy-in from your clinical lab. The patient examples that I gave for HIV, we had to do send-out labs. And so for drugs that are more chronically administered, the send-out will work because you can generally get the concentrations back in about a week or so. And that's the advantage of a Bayesian approach. You can sort of immediately get to your target without having to sort of putz around trying to empirically guess a dose change. So it is a limitation, but it can be overcome with some work.
Maybe one last question in a perspective manner, that in general, healthcare community is far from doing data analysis. So Dr. Neely, as a physician, and you have to bring a lot of people understand what it is. So what is your advice to our upcoming Viera Health Science Center students on taking the training in these quantitative aspects?
It is a challenge. I totally agree with Dr. Tran, though. R is an amazing tool, and there's tons of free resources on learning R. So no matter what field you go into, if you're going to be doing data analysis and presentation, whether it's in pharmacometrics or something else eventually, R is worth your while, and you can learn from that. Obviously, you can look around at your local institution to see if they offer coursework that can either be audited or even some sort of a degree granting program that you might have as a benefit as an employee. That's what I did. My master's was basically I got as an employee at USC, and that's where I first learned R. Actually, was through that coursework, and obviously I've taken it with me. So I think that would be my advice. Look into R. It's a phenomenal tool, and it's free. It's hard to argue with that.
Thank you. Thank you. With that, I think I would like to make some concluding remarks. Thank you again, Dr. Tran, Dr. Neely, for your time and excellent presentations. Just wanted to tell that we do have an internal certificate program, which is a one-year program. We got our first batch taking second semester courses this year. But this is a resource where we try to educate on the fundamentals, not any software specifically, but all software, but fundamentally the principles of pharmacometrics. All the information is on our website. Please do reach me if you have any further questions. And also any further questions on the speakers, please do reach out to me or Dr. Neely, Dr. Tran. The slides will be provided after the meeting. And with that, I thank you everyone. This is our College of Pharmacy family, and we wish you all the best new year ahead and stay safe and healthy. Thank you all for joining us.
Thank you. Thanks for the opportunity. Yes, stay well, everyone.
So